Hi guys, welcome to the session. So in ECG, we are gonna make it easy. The squiggly, wiggly lines are gonna be analyzed by you like a pro champion, so that you are able to analyze them in the real world as well as when it comes to multiple choice questions as well. So what I have today before you are a couple of set of pretty straightforward questions that I had conducted in the app. And I can say that nowadays a lot of people might be using these health gadgets, Apple Watch, for example, Samsung Watch. They're all like FDA approved for at least detecting atrial fibrillation. But then the good thing is, if you are an Apple Watch user, or like if you have a patient who's using an Apple Watch, they can take an ECG by simply putting their finger on the dial, and then that ECG can be sent over to you as well, right? So let me say we have a patient who has sent me a Apple Watch data for today, and my job would be to analyze the rhythm. And I have given a couple of options as well so that I can make it relatively easier for you. So we can get started. Just let me know the audio and the visual part is perfect, and then we can start analyzing these squiggly wiggly lines, as I love to call it. As far as the relay is concerned, I think it's a YouTube live session that we are doing today. So you can hit the comment button, and in case you are listening to this in later, the recorded part of it, then you can in the comment box basically mention the word ECG PDF, and I can share the PDF with you subsequently. So with these words, I think we are good to start as far as today is concerned. The main objective would be that you are able to analyze things at the shortest possible time frame. Very good evening, everybody. Yeah, Apple Watch is not for analysis. It can record ECG. It will not tell you a diagnosis, man. It will not tell you a diagnosis, right? I mean, how can you expect a device? It's a doctor who will tell the analysis, but it can conduct an ECG. No, my point is somebody, and they have put a disclaimer. If you are using an Apple Watch, he will himself say it's not useful for diagnosis of heart attack. It's only for detection of atrial fibrillation, where there would be an irregular rhythm. So a doctor will obviously, I mean, how can guys, there's a lot of this thing going on. AI will replace doctors, and like, we'll be jobless. No, man, it's not possible, right? AI is something that is complementary to our job, right? Like, for example, somebody collapses while walking in the park. So we have tech now by which the Apple Watch will detect a fall, and it will automatically like send the current health vitals and the location of the patient to the loved ones, and sometimes even to the hospital, so that the patient can be taken care of. So it's obviously not gonna diagnose, it's just gonna give a recording, and then you have to analyze. So I'm getting very good answers here. Like one I got is a monomorphic ventricular tachycardia. My suggestion to you guys is, every time you are given a ECG, the first thing that you're supposed to do is calculate the heart rate. And why this is not a ventricular tachycardia is because the heart rate is 100. I cannot call it a monomorphic ventricular tachycardia. I mean, for a diagnosis of a ventricular tachycardia, guys, whether I say monomorphic, whether I say polymorphic ventricular tachycardia, the heart rate of the patient has to be more than 100. So the first learning point for everybody is that in the first 5 seconds, when you check out the ECG, just check out lead number 2, the rhythm strip, and analyze the heart rate of the patient. And here, the question was basically designed to help you understand that not everything that is a broad QRS complex would be thought of as like, that this is a ECG related to ventricular tachycardia. Yeah, that is like a good hint that in the paper, or like as a shortcut when you're sitting for an exam, you say that, okay, it's broad QRS complexes. You say the word premature ventricular complexes, but a lot of people have now got the hint here that this broad QRS is associated with a normal heart rate. And because the heart rate of the patient is normal, therefore we are gonna get this rhythm in a patient who has recently been thrombolized. For example, a person had a myocardial infarction and he went to a non-PCI equipped center. Now, in a non-PCI equipped center, and it's like more than 2 hour distance to the main city, then like patient came at Alwar, right? Alwar is like, pity 4 hours drive or 3 hours, 3.5 hours drive from Delhi. So it's a non-PCI equipped center. And then because the transit to Delhi will also take time, or to Gurgaon will also take time, so we'll advise a thrombolysis. And after thrombolysis, you will notice that the rhythm that will come up is option number A, that is accelerated idioventricular rhythm. This is I can say seen less nowadays, because most of the time the ST elevation MI is being managed with PCI. Even for non-ST elevation MI in high risk cases, percutaneous coronary intervention is being done. But then this is what I've highlighted and is given in Harrison also, that post MI thrombolysis. That is when you have a successful recanalization of the coronary artery. Listen to my words carefully. I said you are having a successful recanalization of the coronary artery. then the ST elevation will start coming back to normal. But then over and above this, you will also start getting is a accelerated idioventricular rhythm. The meaning of this is that you see the good news is that you have destroyed the clot in the coronary artery of the patient, but because of hypoxia, there is a damage to the muscle, and due to damage to the muscle, the ventricles are contracting without getting activation from the SN node. So the word is idioventricular rhythm, because normally you have SN node controlling the ventricles of the patient, but here because of hypoxia, you see in myocardial infarction, you read the word stunned myocardium, na? So stunned myocardium will not be able to contract like normal. Thankfully, it is not. The good thing about AIVR is that it does not cause hemodynamic compromise. In fact, I can say like this, AIVR happening in a post-MI patient is good news, because it is indirectly telling you that the coronary artery in the patient has recanalized and the ST elevation is coming back to normal. And since I've ruled out 2 ventricular tachycardias here because the heart rate is normal, what I'll do is draw a quick diagram with respect to a ventricular bigeminy, which is a common arrhythmia that is seen with digoxin toxicity. So if you look at the sketch that I made infairly, you can notice that I've shown a normal sinus rhythm, then I've shown a PVC, then I've again shown a NSR and a PVC. That would indicate a ventricular bigeminy. The bottom line is all the 4 things that are mentioned on the slide at the moment are having a broad QRS. If heart rate was more than 100, the size of all of them was equal monomorphic VT. If the size was variable, I'll say polymorphic VT. If the heart rate is normal, then you call it a AIVR. And if you have alternative NSR with a premature norm NSR with a PVC alternative happening, we will call it a ventricular bigeminy. So in case you have not given this test in the app, do try to have a look at it. The objective is to tell you that a lot of things are looking obvious, but they may turn out to be opposite of whatever we are thinking it to be in the actual exam. So we are sorted for the first one, moving to the second one. I think Bashishta asked what is the cause of this. Then the cause for this, as I explained, was that the hypoxic myocardium, the stunned myocardium, is now getting supply of oxygen. So luckily it's able to contract, but it's contracting without the control of the SN node. So we call it a idioventricular rhythm. Okay, so coming to the next one, we have a patient with palpitations. Quickly hit the comment button. What is the rhythm that is shown here? What is the rhythm abnormality that is shown here? And I can see that the heart rate of this patient would be something like, I can say 1.5 to 2 large squares. Like mathematically speaking, the heart rate of this patient is hovering like 300 divided by 2. I can say that a little less than 150 is the heart rate at the moment. Somebody commented A for this guy. That's gonna be atrial rate of 150. So it is the ventricular rate, na bache? It is the heart rate basically means the ventricular rate, na? So why the answer is not A for this particular question is that it is written atrial rate. It is not an atrial rate. It is a ventricular rate of 150 per minute. So we are not supposed to assume an answer to a question. So that's why option number A is ruled out. Well, the rhythm in this case is not PSVT, guys. In a PSVT, there is bound to be a very characteristic ST segment depression. There would be hidden P waves present, but this is simply very classical atrial flutter. In atrial flutter, you can count 1 wave before every QRS complex. I've explained to you every time in an atrial flutter, if you are able to count 2 waves, you will say 3:1 conduction. If you are able to see 1, then you will say 2:1 conduction. So in this particular case, I can say that this would be a 2:1 conduction that is happening in a patient. So this looks to be the okay answer. Drug of choice is adenosine, no E. Adenosine is the answer for paroxysmal supraventricular tachycardia, in which we get that characteristic narrow QRS with an ST depression, and then we get these waves which are hidden P waves, and sometimes we can get retrograde P waves also. So yeah, this ECG may look like that of PSVT initially, but then I'll highlight or sketch it once again, showing that characteristic feature that we get in a AV-NRT, that is a AV nodal reentrant tachycardia. So if you analyze this, this is not PSVT, so adenosine is ruled out. And if it was PSVT, then ice pack is also used. 2:1 block basically means that one impulse is getting conducted, when there's a macro reentrant circuit in the right atria, then one impulse is finding the AV node refractory. So all you are getting is a flutter wave. But the second impulse is causing activation of the AV node, so the impulses are going down. So we are going to call it a 2:1 conduction defect that's occurring in this condition. What I mean by 2:1 conduction at the moment is that one is bouncing off the AV node because it is refractory. Impulse did not get conducted to the ventricles. And the second one that got conducted is causing a QRS complex. So the reason why you are getting like a R and a S complex here is that some impulses are going down in the ventricles. While one impulse is going down, the AV node is refractory, so the next impulse bounces it off, and once it bounces off, then I can say we can see a bounced reflex also in the form of this very peculiar sawtooth wave of flutter waves that are present. So no, this is not a heart block. This is not a heart block, guys. This is a 2:1 conduction that is occurring. What I mean by 2:1 conduction is that for this particular case, there is going to be a problem with respect to the impulses going down. So every time we read about atrial flutter, like we say 1:1, you see in atrial flutter, 1:1 conduction would be lethal, na? Because then the impulses will go down faster in a patient. So we have to use our agents that will increase this conduction delay, because of which like 2:1, 3:1, that means ventricular rate will improve in a patient. No, so the point in this case is that where is the P wave, the conducted impulse? That's the point. There is no SC node, the boss of this condition. It is a macro reentrant circuit, man. So read the main videos. I think without that, it would not make sense to be able to analyze this. But yeah, there is no P wave present here. That is why there's a flutter wave. The flutter wave will override the P wave, the SN node area of the patient. That is because there is a macro reentrant circuit in this particular case. So yeah, there is no drop beat because we are not talking about a heart blocks in this case. We are talking about a 2:1 conduction that would be occurring in a atrial flutter. Moving to the third one, a patient comes to me with this chest pain for the previous 4 hours since waking up in the morning. And then we can find this very, very characteristic ST segment changes in lead number 1. I can see it in lead number 2 also. Then you can notice that even in V2, in V3, V4, even in V5, we are having this ST segment changes. So it is unlikely to be an anterior wall myocardial infarction, because the findings which are present are having, like I got extensive anterior wall MI also is an answer. In myocardial infarction, you would be having a ST elevation that would be convex in the upward direction. But in this case, the ST elevation is concave in upward direction. So that makes it easier for us to comprehend. And if it was anterior wall MI, then the findings would have been present in 1 AVL, then V2, V3, V4. But here even lead 2 is getting involved, no? Here even the lead 2 is getting involved in a patient, and then I can say that we are getting findings even in V5, but all of them are having a ST elevation which is concave in a upward direction. So therefore, the analysis of ours based on the limited history that we have is acute pericarditis. I mean, if we mentioned the word pericardial friction rub, then it would have been relatively easier for me. So yes, there's going to be a mixed bag. Like, there would be some that will sound like a little tricky ones. There would be some that can be analyzable, right? The first one, if somebody has not read about it or listened to it, I mean, this would be a bouncer. The second one is like you need to know about the macro reentrant circuit and then the conductions that can be occurring in atrial flutter. There would be no P wave present in a patient. That's why, like, that flutter wave is coming. And then is acute pericarditis, which I think was one of the easier ones in this case. So we are sorted for this. Moving to the next one, he says, what is the correct interpretation shown here? The findings that are present in this case, as far as 1, 2, and 3 are concerned, I can say that there is no ST segment changes that are very much visible. But as I scroll through the lateral part, you can notice the tombstone pattern coming up. The tombstone pattern can be seen in V2, it can be seen in V3, even in V4, even going into V5, and some part even I would say in V6 as well. So therefore, you guys can comment here. The diagnosis in this case would be anterolateral myocardial infarction. Why anterolateral? Because the changes are anterior wall MI would be anything between V2, V3, V4 along with lead 1 and AVL. But in this case, the additional thing that I'll put up is that the ST segment changes are found in V5, V6 as well. And the ST elevation that is present here is having that very classical tombstone pattern. We might even be calling it a party sign. So this would be anterolateral myocardial infarction in contrast to an anterior wall myocardial infarction. Yes, that convexity part is understandable. Along with that, we also might use the word tombstone or a party sign for this. So 3 and 4, it's just to help you realize that there are two types of ST elevation that you need to remember, the concave and the convex one. And then we have a cove pattern as well that we study subsequently. And you guys hit the comment button. Why isn't to Uh, Harshvardhan. Okay, so I think you are listening to our earlier part and we have moved on to the later part. That 2:1 is gonna be, I'll show you the ECG of that. That 2:1 conduction is a variant of Mobitz to heart block where you get drop beats present. But at the moment, what I was describing before you was a 2:1 conduction that is occurring in a case of atrial reciprocal changes in this ECG, yeah, there are present, no? Like you can notice some ST segment depression that is coming up in lead number 2 and 3. In fact, that is what I was trying to point out initially. I deliberately like said ST elevation is not present in 1, 2 and 3. So I was like trying to be at that moment discreet in coming out with the answer to the question. But now where I put in the arrows, you can notice that there is some magnitude of ST segment depression. So reciprocal changes are present in this Shubham. And Harshvardhan, the aspect of heart block is different from the 2:1 or 3:1 conduction that can occur in atrial flutter. In fact, for those of you who have just completed cardiology, just when you go through the main videos, in the end, I've discussed image-based questions on the ECG. And if you listen to them, that will make it like your life a little easier. And then obviously like the next step would be to graduate to the current thing that we're discussing. So moving to the fifth one for today, you can see that he says what is the correct interpretation that can be seen. I'll do the counting here for the heart rate. This would be like, something like about 60 beats per minute is the heart rate of this guy in lead number 2 that I can see. Then you're supposed to calculate the axis, see for the PQRS, whether there's a normal sinus rhythm. So yeah, it looks like a normal sinus rhythm. The heart rate of the patient looks fine. The axis also does not show very significant changes, but you can notice very characteristic, very symmetrical T-wave inversions that are present in even V1, but then in V2, V3, they are like, and even V4, they're like very prominent ones. So you can hit the comment button with respect to this, what would be the interpretation in this case. There is hypokalemia that is coming up in the discussion. Good one, in hypokalemia, there is bound to be other changes also present. Like one of the changes that you would usually get in hypokalemia would be a prolonged PR interval. Then we get a QT prolongation, then we get a QU prolongation, presence of U waves. So I'm not able to see any U waves in this case. So considering that there is a T wave inversion that is present in the anterior leads of the patient specifically, heart rate is about 60 per minute. I'll say that I'm dealing with a case of, okay, very good, Harshvardhan. That is a good input you gave, posterior wall MI. I'll give inputs for posterior wall MI in just few seconds from now. I'll mark the answer in this case. What we are dealing in this case would be a anterior wall myocardial infarction. So yeah, in hypokalemia, we will be getting a T-wave inversion, but then it would be present in all leads, na? In hypokalemia, if you are getting a T-wave inversion, then T-wave inversion would be present in all the leads. Now, hypokalemia will not be selective, but myocardial ischemia is selective based on the coronary artery anatomy. So the reason why the answer is not hypokalemia is कि देखो जो lead number 2 है उसमें तो आपको T-wave inversion नहीं दिख रहा है ना. T-wave inversion is present in only the selective lead. So when I say the word selective lead, they would follow the coronary artery anatomy, and that is like V2, V3, V4 is where we are seeing it. So because we're not getting an ST elevation, we're getting a T-wave inversion. This goes in favor of a anterior wall because V2, V3, 4 will read the anterior wall, and there is a non-ST elevation MI. Now comes a question which somebody said very rightly, why is this not posterior wall MI? That is what is like, I think a lot of you will be sitting for INI-CET. So you need to get this fact right, that for posterior wall MI in V2 and V3 क्या देखना होता है. I conducted a ECG based session even earlier, उसमें भी मैंने ये बताया था that you will be able to see that there would be an ST segment depression, understandable, but उसमें upright T wave होती है. इसमें देखो जो T wave है वो upright नहीं है ना, it is going down. In posterior wall myocardial infarction, you will be able to see the ST depression, वो तो ठीक है. But at the same time, in posterior wall MI, I mean, when you suspect posterior wall MI versus a non-ST elevation MI of the anterior wall is what I'm saying, कि अगर question में ST depression के साथ में upright T wave V2 और V3 में present है, तो you will ask your technician to put V7, V8 and V9 and say this is posterior wall MI. Even in the MCQ, V7, V8, V9 is not given, doesn't matter. You will still suspect on the basis of upright T wave, but otherwise in myocardial infarction, you always get a T wave inversion now. So for non-ST elevation MI of the anterior wall, the changes will again be present in V2, V3 and V4, but this time the ECG that would be coming up would be, I'll use a different color to highlight it. That's the second sketch that is coming up your way. You will be getting is ST depression once again, and then I am showing a T wave inversion only, or rather I can increase the magnitude of the T inversion that has actually occurred in this case. So I hope I'm able to communicate this to you, that if you are gonna get a question on especially ST depression इन V2 एंड V3 तो सीधा posterior वाले MI मत बोल देना, देख लेना कि अपर T wave है या नहीं है. Like at the moment ST depression coming up, and then that very peculiar down T wave that has been shown. So this is non-ST elevation MI. A non-ST elevation acute coronary syndrome that will be involving the anterior wall of the patient. The final diagnosis is answer number B for this one. So we are sorted for the fifth one. Let's look at the sixth one on the agenda for today, which is correct about the pattern that is shown. Okay, fine. Now guys, check it out. This is the INI-CET question I'm talking about. यहाँ पे जो लीड नंबर V2 है और लीड नंबर V3 है, उसमें आप देख रहे हो कि एस्टे डिप्रेशन तो आ रहा है, पर एस्टे डिप्रेशन के साथ में टी वेव को देखो ना, टी वेव अपराइट आ रही है, टी वेव जो है वो अपराइट आ रही है. सो देयरफॉर यू विल से दैट यू आर डीलिंग विद द केस ऑफ पोस्टीरियर वाले एमआई. सो दोनों ईसीजीज को एक बार कंपेयर कर लेते हैं. इफ आई जूम आउट यू विल नोटिस दैट देयर इज अ एस्टे डिप्रेशन इन द सुपीरियर वन एज वेल एज द inferior one, but the fundamental differences with respect to upright T wave versus a T wave inversion, which will change the answer in the question. So this one is I can say query posterior wall MI, and what I would like to do is a V7, V8, V9 evaluation. So we are sorted for the sixth one. Good, Abdul, that you picked it up. And we come to lawn tennis player collapsing on the pitch. The language of the question, I've made it a little smaller. This is again a recap from the INI-CET 1. Lawn tennis player collapsed on the pitch, and then especially I would like you to focus on the precordial leads, that is V2, V3, and yeah, even V4 as well. Do you want me to draw this before you? Okay, I'll do that. This is like the R, that it's the S that is coming, and then we can see this notching thing with the T wave inversion. You can notice T wave inversion coming up in V2, V3, V4, and then there's that notching that is present. The moment that notching is present, I'll just zoom it in as well. We are going to call it a epsilon wave, and that epsilon wave would help you in identifying a arrhythmogenic right ventricular dysplasia. Though in the question he had also shown a histopathological specimen, he said the lawn tennis player had collapsed and there was presence of fat in the myocardium. I removed that pathology image there because that I have discussed in one of the pathology slides that I've already done in my previous session. So for today, the message is that even without a pathology slide, even without seeing fat in the myocardium, fibrotic material in the myocardium in a histology slide, I am able to pick up the epsilon wave in the precordial waves. And this patient, hit the comment button, guys. What will be the treatment advice for this patient, considering that this patient survives? Like this person has Osborne wave will come up, bache. Bashishta Day, the Osborne wave will come up today. So just be patient another 10 minutes and you will get it. So this is like the 20 most important ECGs that you can get in the exam. 30 minutes is the time that I will take to cover the most important ECGs, 20 most important ECGs that can come. If you get this right, then I can say the fact that you are getting a hang of the world of ECG. I'm not saying that I'm making you a nerd at ECG diagnosis. Absolutely not. Nobody can take a claim to saying I have taught you this and therefore this is how you are going to be operating in real practice or like in an exam. But yep, I mean, if you put in an effort of like 30 minutes of your time and learn those 20 ones, you are very much sorted. Yes, the treatment that you'll advise in this patient is an implantable cardioverter defibrillator that will help in terminating any tachyarrhythmia that would be present in the patient. Yeah, if you are an FMG student, you can listen to the easier ones that I'll be discussing. Okay, comment on the diagnosis that is shown subsequently. So let's do the heart rate evaluation in this case, as we always do. So the heart rate is doing pretty fine, about 75 beats per minute. Even if I scroll like here, no, 3, 4 something, so heart rate is doing good, 75. Then is heart rate is jumping up, no, so I'm 2.5. So if I say 2.5, suddenly there's a jump in the heart rate of the patient. Like everywhere here, the heart rate is 75 only, right? That is perfectly normal. This is perfectly normal, 75. But yeah, between this 2.5, I can say that the heart rate is jumping up to 125 beats per minute. So considering that in this patient, the heart rate is normal, we cannot be saying Mobert's one heart block, because in Mobert's one heart block in a patient, there has to be presence of a bradycardia. Now, in all of these questions of heart block, what you're supposed to pick up is that there should be a presence of bradycardia. So like if you're an FMG student, तो आपको क्या पता होना चाहिए कि भाई हार्ट ब्लॉक का मतलब होता है ब्रेडिकार्डिया. इसमें तो ब्रेडिकार्डिया है ही नहीं ना कहीं पे, हार्ट रेट या तो नॉर्मल है या बढ़ गया. तो आंसर क्या करना है, एक्सक्लूजन से. यस वशिष्ठा, यू स्पॉट ऑन. अब्दुल, couple of other people, this would be answered by you as premature atrial contraction. So the correct answer here is D, based on वो यहाँ पे जो एट्रिया जल्दी कॉन्ट्रैक्ट करा है, therefore there's a tachycardia that is happening in a patient. मतलब premature, इंग्लिश में करो ना, premature atrial contraction happening. So this question is based on like exclusion capability. It is not on the fact कि आपको premature atrial contraction आना चाहिए. It is कि आपको ये पता होना चाहिए कि भाई जब भी हार्ट ब्लॉक होता है तो ECG में ब्रेडिकार्डिया होना चाहिए, या तो टैकी भी हो गया, right? So that's the concept to be understood here. Moving to the next one. Fine. In this ECG, when I zoom in, you can notice that this is a normal sinus rhythm happening. You can see a P. I'll sketch it here also, P. Then you can see RS, and then a bit of T wave inversion that is happening. और फिर एक positive deflection आ रहा है. This is the positive deflection that I can pick up in this case. This is the positive deflection that I'm picking up in this case. You can continue with your answers here. That's the positive deflection that I made. I'll just sketch it once again. Moving ahead. This is PRS, T wave inversion, then again a P that is happening. यहाँ पे multiple P's are ना, multiple P's are coming in the ECG of this patient. This one is atrial fibrillation. Which one बच्चे? This one? No. एट्रल फिब्रिलेशन में तो हार्ट रेट 100 के ऊपर होगा ना, तो इसलिए एट्रल फिब्रिलेशन नहीं होगा ना, और एट्रल फिब्रिलेशन में तो पी वेव एब्सेंट होती है. यहाँ पे जो दिखाई दे रहा है बच्चे, व्हाट यू नीड टू अंडरस्टैंड इज कि पी के बाद में फिर से पी आ रहा है, तो या तो ये होगा आपका एक ऐसा सवाल कंप्लीट हार्ट ब्लॉक का, या फिर ये 2:1 कंडक्शन होगी, और इट कैन बी अ मोबिट्स टू हार्ट ब्लॉक ऑल्सो. क्योंकि देखो इसमें जो पी आर इंटरवल है वो चेंज तो हो नहीं रहा ना, देयर इज अ पी आर इंटरवल दैट इज नॉट चेंजिंग. द पी आर इंटरवल इज फाइन, बट बीच में एक पी वेव आ गई एंड देयर इज अ ब्रेडिकार्डिया दैट इज हैपनिंग. अगर आप काउंट करते हो यहाँ पे हार्ट रेट को 1 2 3 4 5 6 8, 300 डिवाइडेड बाई 8 वुड बी अ हार्ट रेट ऑफ हार्डली 30 बीट्स पर मिनट. सो व्हाट यू कैन अंडरस्टैंड इज कि देयर इज अ ब्रेडिकार्डिया दैट इज अकरिंग इन दिस पेशेंट. द मेन थिंग इज जो मैं आपको सिखाने की कोशिश कर रहा हूँ वो क्या है कि देयर इज अ कंडक्शन हैपनिंग. एनएसआर दिखाया मैंने, फिर एक पी वेव नॉन कंडक्टेड है, फिर नॉर्मल साइनस रिदम है, फिर एक पी वेव नॉन कंडक्टेड है. तो जब वो ऑल्टरनेटिवली चलता है, दैट इज अ नॉर्मल साइनस रिदम, पी वेव ऑल्टरनेटिवली, वी विल से दैट दिस इज अ 2:1 ब्लॉक. द 2:1 AV ब्लॉक इज अ डिफरेंशियल फॉर मोबिट्स टू हार्ट ब्लॉक इन अ पेशेंट. सो यहाँ पे व्हाट इनिशियली मुझे लगा कि यार 3rd डिग्री हार्ट ब्लॉक हो सकता है, बट 3rd डिग्री हार्ट ब्लॉक में तो पीपी एंड आरआर इंटरवल का डिफरेंस होगा, नंबर ऑफ पी वेव्स और नंबर ऑफ आर वेव्स मैच नहीं करेंगे. तो उसका भी ECG आगे दिखाता हूँ आपको जिसमें 3rd डिग्री हार्ट ब्लॉक होता है. लेकिन अभी के लिए मैसेज है कि कभी भी अगर ब्रेडिकार्डिया वाला क्वेश्चन आता है, तो ब्रेडिकार्डिया वाले क्वेश्चन में करना क्या है कि पहले तो देखना है कि मोबिट्स 1 है कि नहीं. मोबिट्स 1 में क्या होता है, देयर इज अ प्रोलॉन्गेशन ऑफ द पी आर इंटरवल. तो इसका आंसर पहला क्यों नहीं हो सकता कि उसमें पी आर इंटरवल बढ़ना चाहिए, इसमें तो बढ़ नहीं रहा है. तो यहाँ पे पी आर इंटरवल तो आपको सेम से मिल रहा है, और वो यूजुअली नॉर्मल रेंज में मिल रहा है. तो ये या तो ये सेकंड होगा या थर्ड होगा, क्योंकि फोर्थ ऑप्शन में अगेन पी वेव और आर वेव का नंबर मैच नहीं करता है. मैंने बोला 2 ऑप्शन इसलिए मैंने बाहर कर दिए कि या तो पी आर इंटरवल बढ़ना चाहिए मोबिट्स 1 में, या पी वेव आर वेव का नंबर अनइक्वल होना चाहिए. वो तो दोनों हो नहीं रहा है. सो व्हाट आई कैन सी इज इधर ये क्वेश्चन होगा मोबिट्स 2 पे, या होगा 2:1 ब्लॉक पे. अब क्योंकि इनिसेट आ रहा है भाई, इनिसेट का फ्लेवर ऑफ द मंथ है, तो फिर हम इसको थोड़ा सा एटिपिकल सोच के चलेंगे. सो दिस वन वुड बी 2:1 AV block in a patient. The correct answer is option number C for the 9th question. Okay, G. The next one is super easy. Let me know the interpretations here. Yes. Would it be, कुछ बोलूँगा तो एक्चुअली आंसर ही क्लियर हो जाएगा. सो आई विल वेट फॉर योर क्विक कमेंट्स फॉर दिस वन. Twitching around the baseline happening in this case. So this is a ventricular fibrillation. This is not a polymorphic ventricular tachycardia because it is all dancing around. No, bache, this is not a polymorphic ventricular tachycardia because this is all dancing around the baseline. Na? So this is a twitching activity of the heart of the patient. So therefore, what we will do in this case is we will go for a defibrillation. This is not a polymorphic ventricular tachycardia. This is a standard ventricular fibrillation. The only thing is we have zoomed into the image, तो complexes big लग रहे हैं, जिसकी वजह से लग रहा है कि we are talking about a polymorphic VT. जब polymorphic VT होता है तो उसमें baseline तो सेम ही रहती है ना. उसमें तो जैसे what I've shown is that the baseline will not oscillate, right? When I've shown a PVT happening in a patient polymorphic ventricular tachycardia, then अगर ये polymorphic VT होता with the standard baseline present, then I would have said magnesium sulfate, but इसमें तो it's all dancing around the baseline. So because the person is having twitching of the heart, so this is not polymorphic VT, a simple ventricular fibrillation, for which the answer is B. तो ये वाला क्वेश्चन है यार, ये जो FMG एग्जाम में है, राइट? अब FMG एग्जाम में वो ज़्यादा 2:1 नहीं पूछेगा आपसे। FMG एग्जाम में वो बेसिक पूछेगा कि भाई वेंट्रिकुलर फिब्रिलेशन बता दो। अब ये तो आसान है ना यार, वेंट्रिकुलर फिब्रिलेशन तो इज डांसिंग अराउंड द बेस लाइन, लाइक बैग ऑफ वॉर्म्स जैसे बोलते हैं ना, बैग ऑफ वॉर्म्स इज लाइक ड्यू टू मल्टीपल एक्टोपिक फोका इन द हार्ट ऑफ द पेशेंट. सो द आंसर फॉर 10th इज ऑप्शन नंबर बी, अ वेरी सिंपल वन. Moving to the subsequent one, lots of time the ECG might be having interference from electronic devices as well. So let's look at your responses for the next question. This chap, if you look at the heart rate, like this would be something like 2.5, so doing fast, about 125 beats per minute here. If I look here also, something like 2.5, so I can say like, you know, something like 125 beats per minute. So the heart rate is constant in this case. So this initially मुझे लगा कि यार ये जो twitching सी लग रही है, this could be like a atrial fibrillation, but P wave is very much discernible. I mean the P wave is discernible, and in atrial fibrillation the RR interval should be changing. यहाँ पे तो जैसे RR interval देखते हो left to right, it is still the same, but the main thing is the height of the R wave. The height of the R wave is what I think most guys have been able to pick up here, the QRS complexes. The height is changing of the normal duration QRS. जैसे पॉलीमॉर्फिक वेंट्रिकुलर टैकीकार्डिया में जो क्यूआरएस होता है उसकी ड्यूरेशन ब्रॉड होती है और हाइट चेंज होती है. यहाँ पे क्यूआरएस की ड्यूरेशन नॉर्मल है, लेकिन एम्पलीट्यूड जो है वो वेरिएबल है. तो क्योंकि मैंने बोला कि क्यूआरएस का साइज, जो क्यूआरएस की ड्यूरेशन है वो नॉर्मल है और एम्पलीट्यूड जो है वो वेरिएबल है, तो देयरफॉर वी विल से दैट वी आर डीलिंग विद द केस ऑफ इलेक्ट्रिकल ऑल्टरनेंस दैट वुड बी सीन इन लाइक अ पेरिकार्डियल एफ्यूजन एज पीपल कमेंटेड. And yep, I mean the main aspect that you need to remember is अगर ये साइनस एग्जिट ब्लॉक होता तो ब्राडिकार्डिया प्रेजेंट होता तो बी तो बाहर हो जाता है. मल्टीफोकल एट्रियल टैकीकार्डिया में तो फिर देयर इज अ वेरिएबल एम्पलीट्यूड ऑफ द पी वेव जो आगे मैं आपको दिखाऊंगा, that is usually seen in patients of COPD that we will be discussing subsequently. So two options were ruled out और बाकियों से हमें एनालाइज करना था. साइनस एरिथमिया तो नॉर्मल हार्ट रेट के साथ होता है. Sinus arrhythmia is with a normal heart rate, that is like a vagus का जो discharge है that will keep on changing whenever we are breathing in and out. So the answer here is electrical alternans. Okay, so this is again a favorite for the INI-CET people. Like what I'm doing is a mixed bag here. बीच में हम FMG वाले क्वेश्चन भी डिस्कस कर रहे हैं. ये तो टिपिकल INI-CET वाला है. मतलब आई थिंक 2021, 22, 23 में तो पीछे ही पड़ गया था इस वाली ECG के कि हर बार देर इज गोना बी ए चेंज इन द वर्टिकल हाइट ऑफ द पी वेव. जैसे आप देख रहे हो यहाँ पी वेव, वर्टिकल हाइट पी वेव की चेंज होती जा रही है. सो इरेगुलर आरआर इंटरवल तो है, वो तो मैं मानता हूँ कि देयर इज अ इरेगुलर आरआर इंटरवल इन दिस केस. जैसे यहाँ पे हार्ट रेट जो है दैट इज अबाउट 150 पर मिनट. एग्रीड. इफ आई मूव अ लिटिल लैटरली तो यहाँ पे जो नंबर ऑफ बॉक्सेस हैं वो थोड़े इंक्रीज हो जाते हैं. समथिंग लाइक आई कैन से नॉट एग्जैक्टली 3 बट 2.5 के आसपास थे. तो हार्ट रेट जो है वो अ लिटिल मोर देन 100 और 125 के आसपास होगा. तो व्हाट आई वांट टू जस्ट से इज, आई मीन दैट देर इज अ इरेगुलर आरआर इंटरवल इन दिस पेशेंट, बट बिकॉज यहाँ पर देर इज अ वेरिएबल पी वेव एम्पलीट्यूड. सो वेरिएबल वर्ड मैंने 3 बार बोला है. एक हो गया क्यूआरएस कॉम्प्लेक्सेस के लिए जो कि ब्रॉड है, तो पॉलीमॉर्फिक वीटी. Then is I mean the height is also variable and the duration जो है सबकी broad है, that is polymorphic VT. Second time is QRS duration is normal but the height is varying, that is electrical alternance. और अभी मैंने बोला कि there is like a variable P wave present and there is a tachycardia with the irregular RR interval. So this is classical for MAT, that is called as multifocal atrial tachycardia. So the 11th one that we discussed was electrical alternance. This one is MAT. Let's move to the next one. यस गाइस, हार्ट रेट से कर लेना भाई, हार्ट रेट से कर लेना. 1 2 3 4 5 6 7 8 9 10 11. तो मतलब हार्ट रेट तो बिल्कुल ड्रॉप हो गया, लेस देन 30 बिट्स पर मिनट है. ब्रैडिकार्डिया है, सिवियर ब्रैडिकार्डिया प्रेजेंट है. यस, जब हार्ट रेट 30 के आसपास है, पी वेव और आर वेव का नंबर मैच ही नहीं कर रहा है, देन वी विल से लाइक इसका तो पीपी इंटरवल और आर आर इंटरवल के बीच में बहुत ज़्यादा गैप आ रहा है ना. अब देखो ये आर और आर के बीच का गैप हो गया. आई यूज अ डिफरेंट कलर. द नंबर ऑफ बॉक्सेस बिटवीन द आर एंड द आर वेव एंड द नंबर ऑफ बॉक्सेस बिटवीन द पी एंड द पी वेव इज नॉट कांस्टेंट ना. P followed by P हो गया, but तो पहली बात तो ऐसा नहीं होता. PP and RR interval is variable, so we will say this is a third degree heart block for which we will have to use a dual chamber pacemaker. जो कि अगेन एक क्वेश्चन था, जो FMG एग्जाम था उसमें उसने डायग्नोसिस वगैरह नहीं पूछा, उसने एक्सरे दे दिया एंड उसने पूछा कि पेशेंट को स्टोक्स एडम सिंड्रोम है और उसमें 2 वायर्स दिखाई दे रही थी, तो उसने बोला कि कौन से वाला पेसर है, तो यू विल से दैट दिस इज अ डुअल चैम्बर पेसमेकर. व्हाई नॉट 6 साइनस सिंड्रोम, क्योंकि पी वेव दिख रहा है ना बच्चे, ये देखो ये पी वेव यहाँ पर प्रेजेंट है, पी वेव प्रेजेंट है, मैं इतनी बार पी वेव मार्क कर देता हूँ, तो इसका आंसर 6 साइनस सिंड्रोम क्यों नहीं है, बिकॉज 6 साइनस सिंड्रोम में पी वेव एब्सेंट होती है, जबकि यहाँ पे तो इतनी बारी पी वेव आपको दिखाई दे रही है. 6 साइनस पे अंग्रेजी से करो ना, पी वेव का मतलब 6 साइनस का मतलब यही होता है कि द पी वेव इन द पेशेंट इज मिसिंग. यस. ओके जी. नेक्स्ट इज अ पेशेंट वेयर यू आर गेटिंग दैट क्लासिकल साइन वेव पैटर्न. तो ये तो मुझे मतलब आई थिंक दिस इज लाइक वेरी क्लासिकल साइन वेव पैटर्न दैट यू कैन पिक अप हियर. ब्रॉड RS complexes present. In fact, even the vertical height of the T wave is increasing in this patient. Right, tall tented T waves are coming up. So one in this question is I've shown is tented T waves, that is the tall tented T's. Second, I've shown that sine wave pattern coming up, so hyperkalemia. And every time you have a hyperkalemia, you need to give calcium gluconate for management for antagonism. लेकिन बोलता है कि लोअरिंग ऑफ पोटेशियम कैसे करोगे, तो फिर हम इसमें इंसुलिन ड्रिप चला देंगे, लेकिन उतना तो उसने पूछा ही नहीं भाई, उसने तो टॉल टेंटेड टी वेव दिखाई है और फिर कैल्शियम ग्लूकोनेट के बारे में पूछा. ओके जी. मूविंग टू द 15th वन फॉर टुडे. व्हाट इज द लाइकली कॉज ऑफ द ECG चेंजेस एयर. देखो इसको एनालाइज कैसे करना है, कि स्टैंडर्ड क्वेश्चन है नीट PG टाइप का. डिजॉक्सिन ना हमेशा एस्टर डिप्रेशन करता है, तो आप किसी भी लीड में देखोगे तो आपको एस्टर डिप्रेशन दिखाई दे रहा है. डायूरेटिक्स करते हैं हाइपोकलीमिया, एस इनहिबिटर करते हैं हाइपरकलीमिया, और एंजियोटेंसिन रिसेप्टर ब्लॉकर भी करते हैं हाइपरकलीमिया. तो या तो इसमें टॉल टेंटेड टी वेव्स होनी चाहिए, तो यहाँ पे एस्टर डिप्रेशन भी नहीं दिख रहा है और यहाँ पे टॉल टेंटेड टी वेव्स भी नहीं कहीं पे दिखाई दे रही हैं. तो कंसिडरिंग द फैक्ट कि आप बाकी सारी बातें छोड़ दो, हाइपोकलीमिया को हमेशा लास्ट में कंसिडर करना, दैट या रिवर्स टिक साइन फॉर प्रेजेंस एयर. यहाँ पे जो दिख रहा है सर, दैट इज लाइक अ स्मॉल पॉजिटिव रिफ्लेक्शन जो कि टी वेव के बाद में आ रही है. यहाँ पे जो मेन पॉइंट है वो है कि क्यूटी इंटरवल जो है वो प्रोलॉन्ग्ड है. जो क्यूटी इंटरवल है पेशेंट का, दैट क्यूटी इंटरवल इज शोइंग इज अ प्रोलॉन्गेशन. और क्यूटी इंटरवल के साथ में लाइक इट्स नॉट अ वेरी ऑब्वियस थिंग दैट इज यू वेव इज नॉट वेरी प्रोमिनेंट फॉर दिस वन, बट आई कैन से दैट यू वेव अगर मुझे नहीं भी दिख रहा है, देन व्हाट आई वांट टू हाईलाइट इन दिस पर्टिकुलर क्वेश्चन इज दैट आप इसको एक्सक्लूजन से करोगे कि भाई एस इनहिबिटर ARB के साथ हाइपरकलीमिया होना चाहिए, तो टॉल टेंटेड वेव नहीं मिल रही मुझे, एंड एस्टर डिप्रेशन और रिवर्स्टिक साइन नहीं है. सो आई गो इन फेवर ऑफ लाइक द diuretics component, though I'll not say that a very classical U wave is present here and a very classical QT prolongation can be measured, but like there are some of them where you will have to do analytical capability. This is one of them present. No, doctor, I'm not saying that that would be a U wave. It should have been present here. It's not a very good deflection, I can say. But yeah, what I can say is that इसमें जो QT interval है, that is like a little normal QT interval था 9 to 11 small squares का. तो यहाँ पे जो QT है दैट वुड बी लाइक इंक्रीज अ लिटल ऑन द हायर साइड ऑफ नॉर्मल, बट या डिफिकल्ट टू डायग्नोज प्रैक्टिकली. सो मैं मानता हूँ तो ऑप्शंस के बेसिस पे हमें सॉल्व करना है यहाँ पे दिस वन. सो 15th इज द आई वुड से द लीस्ट डिस्क्रीट फाइंडिंग दैट आई हैव डिस्कस्ड बिफोर यू, बिकॉज अब सारे वाले तो ऑब्वियस नहीं होते हैं, तो सम ऑफ देम दैट आई हैव टू इनकॉर्पोरेट आर लाइक द वंस वेयर यू विल हैव टू डू अ बिट ऑफ एक्सक्लूजन कैपेबिलिटी, बट प्रैक्टिकली या नॉट पॉसिबल विद द 15th वन. फाइन जी. वी हैव दिस 50-year-old चैप, उसको इश्केमिक कार्डियोमायोपैथी है, उसको एस्पिरिन चल रहा है, लो डोज स्टैटिन्स है, मेटोप्रोलॉल है, आइसोसॉर्बेट मोनोनाइट्रेट है, LDL 100 है, HDL 40 है. तो टारगेट तो थोड़ा हमें 70 के नीचे तो लाना ही है ना. इनफैक्ट ये तो डायबिटिक है, तो मुझे इसका वैल्यू जो है इवन और कम करके 55 की तरफ अचीव करना है. सो फॉर दिस पर्टिकुलर पर्सन आई नीड टू गिव अग्रेसिव स्टैटिन्स फॉर दिस पर्सन, एंड देन ही सेज व्हाट इज द नेक्स्ट बेस्ट इंटरवेंशन. ओके, सो उसने ECG भी दे दिया. तो यहाँ पे तो ब्रैडिकार्डिया वाला कंपोनेंट है ही है बीच में ना, 6-7 6.5-7. तो 700/3 दैट इज समथिंग लाइक आई कैन से समथिंग लाइक 45 per minute. That is the heart rate that is present in this guy. So he says what is the next best intervention. तो अगर आप देखोगे बीटा ब्लॉकर भी चल रहे हैं, there is a prolongation of the PR interval that is occurring in this patient. The PR interval the first time, the second time, the third time जो है वो increase होता जा रहा है. Then you can see a T followed by a P, और यहाँ पे there is a drop, मतलब missed beat है यहाँ पर, there is a missed beat जो vertical arrow मैंने लगाया. So considering कि there is like a prolongation of the PR interval and then there's a drop beat present, the patient is having a first degree heart block. And this first degree heart block is something which little disconcerting because उसको मुझे handle करना है. So what I'll do is considering कि अगर इस question में ECG नहीं दी होती तो मैं सबसे पहले क्या करता इस पेशेंट के लिए कि I would have scheduled a CCTA so that I can analyze this patient's coronary arteries. So suppose if the ECG was not given, considering that उसका HDL का target achieve नहीं हो रहा है and the patient is already having ischemic cardiomyopathy, I want to check for revascularization. So if ECG was not given, I would have answered it as option number C. That is CCTA to evaluate the status of the coronary arteries, and then we can subsequently plan a revascularization procedure based on the PET scan report. लेकिन because first degree heart block है इस person में तो the question is that beta blocker जो हम इसको दे रहे हैं that could be maybe on the higher side of considering the weight of a person, क्योंकि डायबिटिक्स में बहुत बार weight loss भी होता है. तो आई थिंक फर्स्ट हमें अगर ECG के बेसिस पे पूछ रहा है तो वी शुड ट्राई एंड रिड्यूस द बीटा ब्लॉकर की डोसेज इन दिस पेशेंट टू लेट मी से 25 and reevaluate the patient of the ECG of the patient subsequently. But yes, in the same question, if like he was not giving me any ECG with a prolongation of PR interval and a drought beat and a Wenckebach phenomenon, I would have performed a CCT in this patient to determine his coronary artery status. Okay, so we come to the next one, which is no, this is Mobitz one, man. This is Mobitz one. No, yeah, this is Mobitz one heart block. Yes, you're right. I meant वो मैंने बोला तो I think Mobitz one ही है. Prolongation, Wenckebach word बोला ना अभी. तो Wenckebach जो होता है that would be called as Mobitz one heart block. So I'll ascribe that to a lack of hand-eye coordination, right? कि लिखना भी और बोलना भी है. So this would be a Mobitz one heart block or a Wenckebach phenomenon, considering that we would be having is a Wenckebach perspective of prolongation of the PR interval followed by a drop. Yes, Shivan, you were right. It's Mobitz one. It's Mobitz one. That's it. Okay, so a hypertensive patient came in here. There's a embolus in the left atria. तो उससे थोड़ा सा क्लियर हो जाता है. इरेगुलर RR इंटरवल भी यहाँ पे प्रेजेंट है. P waves भी नहीं दिखाई दे रही हैं. So everything is telling me that embolus in the left atria, and more importantly, like there is a irregular RR interval. This is a patient on atrial fibrillation, again a very classical one, and he says कि भाई इसमें next best intervention क्या करोगे. तो कमेंट कर दो यार फटाफट से. अब तो AFib तो बना ही दिया आपने, डायग्नोसिस तो बिल्कुल सही बनाया है 17 नंबर में. ओके हाँ, कुछ भी नहीं लिखा ना पेशेंट स्टेबल है कि नहीं है, तो फिर तो हम बेसिकली ये ज्यूम करेंगे ना पेशेंट स्टेबल है. अनकॉन्शियस लिखा होता तो फिर हम बोलते हैं कि भाई हेमोडायनेमिक कॉम्प्रोमाइज है. अदरवाइज तो वील गो बाय द स्टैंडर्ड एल्गोरिथम दैट इज रेस कंट्रोल इन दिस पेशेंट. सो द आंसर इन दिस केस वुड बी ऑप्शन नंबर ए, दैट इज डिल्टियाज्म. बाकी उस बात का ध्यान रखना कि अगर ये बोलता है कि पोस्ट MI पेशेंट है तो पोस्ट MI पेशेंट में आपने कभी भी डिल्टियाज्म आंसर नहीं करना है, क्योंकि पोस्ट MI इजेक्शन फ्रैक्शन लेस होता है. अगर इजेक्शन फ्रैक्शन लेस है, कार्डियक आउटपुट लेस है, तो वेरापामिल नहीं देते हैं, क्योंकि वेरापामिल एक्ट्स ऑन द AV नोड एंड कॉजेज अ फर्दर डिक्रीज इन द कार्डियक आउटपुट ऑफ अ पेशेंट. सो डोंट आंसर इन एट्रियल फिब्रिलेशन इफ इट इज अकरिंग पोस्ट MI वेरापामिल. दैट्स अ पॉइंट टू बी रिमेंबर्ड. वेरापामिल इज नॉट टू बी गिवन इन अ पोस्ट MI एट्रियल फिब्रिलेशन इफ डॉक्यूमेंटेड इन अ क्वेश्चन. इसलिए बोल रहा हूँ कि ये ऐप में आपको क्वेश्चन मिलेगा. एक पोस्ट MI पेशेंट को सेकेंड या थर्ड डे पे PCI के बाद में एट्रियल फिब्रिलेशन हो गया, उसका इजेक्शन फ्रैक्शन कम है, और आप क्या करोगे, तो वहाँ पे वेरापामिल नहीं बोलना है आपको. दैट इज प्राइमरली बिकॉज द कार्डियक आउटपुट ऑफ द पेशेंट इज ऑलरेडी लो. द आंसर इन दिस केस इज ऑप्शन नंबर ए. वी मूव टू द नेक्स्ट वन. somebody had commented कि सर ऑसबॉर्न वेव कहाँ पर होती है. तो अब मैं आपको प्री कॉर्डियलेट्स में ऑसबॉर्न वेव दिखा रहा हूँ, विच वुड बी लाइक द R एंड देन द S, एंड देन यू कैन नोटिस कि T वेव से जस्ट पहले इट इज दैट special wave that I've highlighted at the moment before you. This would be called as Osborn wave, would also be called as a J wave. इसको mix up नहीं करना है with another one. In fact, I'll just draw this again. This is not to be mixed up with the, I'll just try and draw this again. That's gonna be like, you know, there could be like a slurring like this could be present in the ECG of this patient, and then this would be a epsilon wave that I've highlighted. So what you can see in the ECG of this patient is an Osborn wave, that is a J wave, and J wave is found in patients of hypothermia, not to be mixed up with epsilon. And yes guys, you can comment from the options in this case. What I've myself mentioned is amiodarone देंगे. We'll use amiodarone in the patient, na? Post MI low cardiac output, terminate in arrhythmia, na? So amiodarone would be used in a patient, not beta blockers in a patient. We can use a beta blocker, na? Post MI है तो what पे हम short acting beta blocker दे सकते हैं ना. तो शॉर्ट एक्टिंग बीटा ब्लॉकर लाइक यू somebody put up a query के सर पोस्ट में विरापामिल नहीं देना तो क्या देंगे, तो एस्मोल दे दो, एंड एस्मोल के बाद में एंटी कोएगुलेशन एंड एम्बिड्रॉन वुड बी यूज्ड। ओके। वुल्फ पार्किंसन वाइट सिंड्रोम जो होता है उसमें तो फिर जो चेंजेस होते हैं तो आर वेव में होता है ना, शॉर्ट पी आर इंटरवल होगा, absence of the Q wave, and the changes would be found in the upswing of the R wave of the patient. Why cannot we give anticoagulation for this one? ओके, दैट्स अ गुड वन नो, कि इसमें व्हाट इज द नेक्स्ट बेस्ट इंटरवेंशन फॉर दिस, तो वो एल्गोरिथम होता है ना रेस। ये यही तो क्वेश्चन था यार, यही तो क्वेश्चन था। गुड समबडी आस्क्ड दैट कि सर आपने एंटी कोगुलेशन क्यों नहीं बोला, तो एंटी कोगुलेशन इसलिए नहीं बोला कि पहले रेट कंट्रोल करते हैं, फिर एंटी कोगुलेशन करते हैं, फिर केमिकल कार्डियोवर्जन, और उसके बाद में इलेक्ट्रिकल कार्डियोवर्जन करते हैं। सो द मेन मैसेज इज दैट व्हाई एंटी कोगुलेशन नॉट द आंसर इज द एल्गोरिथम इज लाइक दिस फॉर एनी पेशेंट ऑफ लॉन्ग स्टैंडिंग एट्रियल फिब्रिलेशन। So I think it is sorted. 18th is J wave, and J wave is seen in patients of hypothermia. लेकिन अगर हाइपोथर्मिया नहीं है तो फिर एक आधा सवाल मुझे ऐसे भी डालना था जिसमें थोड़ा आपसे सॉल्व ना हो, दैट वुड बी हाइपरकैल्सीमिया। किसी ने बोला कि सर ब्रुगाडा सिंड्रोम क्या होता है, तो ब्रुगाडा सिंड्रोम में तो कोव पैटर्न ऑफ एसटी एलिवेशन प्रेजेंट होता है, उसके साथ में सैडल बैक टी वे प्रेजेंट होगी। इट्स अ सोडियम चैनल डिफेक्ट SCN5A with sudden nocturnal death की history also given in the question with respect to the elder brother or sister of a patient. So the correct answer for our question is D, and this is not Brugada, it is a Osborne wave that we have shown. Okay जी, moving to the next one. Yeah, co-pattern of ST segment elevation. आकाश चलता रहेगा भाई, ऐसा तो ग्राइंड जो है दिस इज लाइक इट्स ऑलवेज गोना हैपन with us, with everybody. That's how life is. Some days you will score more, some days you are less. So you just need to be persistent. But 100 के लिए तो देखो मैं ये बोलूँगा थोड़ा मेन वीडियोस को कर लो, थोड़े कंसेप्ट्स को ब्रश अप कर लो। Yeah, what I'm saying is there's a question given in the app which is mentioning between selecting between diltiazem, स्मोलॉल एंड एमेड्रॉन, तो हमारा आंसर डिल्टियाजम या विरापामिल नहीं होगा पोस्ट एमआई, दैट्स द पॉइंट। तो बीटा ब्लॉकर यूज कर लेंगे। पहले रेगुलरली तो हम देते ही वही है ना, लाइक वी गिव फॉर एट्रियल फिब्रिलेशन वी गिव बीटा ब्लॉकर्स ओनली। ओके जी, फाइन, आई एम वेटिंग फॉर योर आंसर्स फॉर द नेक्स्ट वन। अब तो मैं बोल बोल के परेशान हो गया। हार्ट रेट जो है नॉर्मल है, 60 है, 75 है, normal sinus rhythm present hai. The guy is having a NSR and there is like a heart rate that is oscillating between normal in a patient. That can happen in anybody with respect to breathing because the heart rate is normal. Therefore, we will say it is sinus arrhythmia. PVCs जो होते हैं उसमें हमेशा broad RS complexes would be present. Premature atrial complexes will always cause tachycardia. Low voltage ECG, the R and the S wave height would be less than 5 millimeter. So if you go by exclusion, the answer in this case would not be like cannot be worked out as option number B, C, and D. The answer is A only. Okay, good heart shows a sinus rhythm. Cool. Let's do the last one for today. 30-year-old patient, the smartwatch is showing the following data. And now you can see that, you know, that retrograde P waves or like an ST depression that is coming up in this case. So considering that there is a narrow QRS in a patient, and apart from narrow QRS, there is a tachycardia, like only two large squares present here. So I'm saying narrow QRS tachy with a very visible ST segment depression, retrograde P waves or hidden P waves, as I can say. So this would be a case of paroxysmal supraventricular tachycardia. And he says that the patient is unconscious. So what I will do in the unconscious, unstable patient would be a cardioversion. The correct answer in this case is option number C. अनकॉन्शियस नहीं होता तो अडीनोसिन देते ना पहले, अगर अनकॉन्शियस नहीं होता पहले कैरोटिड सन मसाज देते फिर अडीनोसिन देते, बट कंसिडरिंग दैट द चैप इज अनकॉन्शियस नहीं होगा यार, ए आंसर नहीं होगा। ये जो क्वेश्चन है ये तो FMG एग्जाम का क्वेश्चन है, वेरी सिंपल एंड स्ट्रेट फॉरवर्ड। सो डन अ मिक्स बैग हेयर, कोई तो नेस्टी वाले है ना, दैट ARVD एंड देन that hypokalemia one which was difficult to pick up practically, but the one that I highlighted at the moment before you is like an FMG exam question only। बोला कि भाई बंदा conscious हो unconscious हो गया तो क्या करोगे, तो then we will be giving a cardioversion for this patient। So we are sorted for today guys, thank you so much for your patience and hearing me out, and like I think in another 45 minutes or so I had a target of 30, but anyway it went a little beyond, but we have tried to do the core must know kind of questions that are done at the moment। So take care guys, god bless you, and keep hammering as I say always, and see you on the other side is what I can say at the moment। ओके जी। या एक बारी तो करना बनता है भाई, 20 ईसीजी ज़्यादा थोड़ी ना होती है। अब बोलो कि सर 20 भी नहीं करें और फिर आप शॉर्टकट बोल दो, तो इससे शॉर्ट क्या बताएंगे, राइट? सो टेक केयर गाइस, गॉड bless you, take care, bye bye, and see you again. We have another session lined up. I think tomorrow is that anatomy session that I'll be taking in the app. That is for FMG students only, but yeah, even if you are an aspirant and you have revised your anatomy, do join in that session for that if you want to revise your anatomy for NEET. So that's a session scheduled for tomorrow. Then there's a medicine session that's scheduled for 5th. So I'll see you again. Right. Take care. Bye-bye. Okay, anterolateral and extensive anterval MI. Bashishta, send me a email at marvamedicine@gmail.com. I'll send you two ECGs, both anterolateral and extensive anterval MI. But I'll say them verbally at the moment. In anterolateral MI, the findings would be found in V2, V2, V3, V4, V4, and V5. Most of the time, not even in V6. It is like V2 to V5 that you'll mainly see. In extensive and anterval MI, it will be V1 to V6. All would be involved. So if you are gonna drop me a mail, I'll send you two ECGs, one of anterolateral and anteroval MI, the common ones, which are the ones that are also asked. So take care, guys. Bye bye. Door to needle time is fast MI, that would be door of not the home but of the hospital, and within 30 minutes we should be doing it as a thrombolysis. Yes, guys. Fine. Yeah, we need to brush up in between. No? Board to balloon type would be 90 minutes for a percutaneous coronary intervention. चलो भाई, टेक केयर आज के लिए, गॉड ब्लेस यू।